Many thanks for the kind introduction and also for the kind invitation. It's a real pleasure to be here. I've already learned a lot, and I'm happy to talk you through the experience we have in the Netherlands with setting up long COVID expertise centers. On my first slide, you see a news clip from the beginning of this month announcing the opening of specialized long COVID expertise centers, and this was a very memorable moment that many patients had been looking forward to, and I will tell you a bit more about how they came to be. I have nothing to disclose. I first would like to give you a little bit of scope in the Netherlands. We have approximately 300 to 500,000 patients with long-lasting symptoms, which is a lot given that we are a population of only short of 18 million. Approximately 100,000 are estimated to have severe symptoms. These are the people who had to drop out of university, who've not been able to return to work, who are not able to care for their children the way they want, and these are the people that we are targeting in our clinics. In addition, there are around 35,000 children with long-lasting symptoms, and specialized clinics for this group will be opening soon as well. So how did we approach long COVID care in the Netherlands? When we first started seeing patients not recovering after COVID, multidisciplinary paramedical care was introduced into the basic health insurance package. This included physiotherapy, occupational therapy, psychosocial support, etc. And normally only evidence-based therapies are covered by our insurance package, so this was a conditional admission whilst waiting for further evidence. However, 3 years later, the Dutch Health Institute concluded that there was no or insufficient evidence for paramedical recovery care. And this aligns with our experience that while some patients do benefit from rehabilitation, many do not, and others even get worse. But this did leave us with a huge gap and an unmet need for care. In the past year, we've been gaining momentum towards the opening of these clinics, and I cannot stress enough how vital patients and patient organizations have been. In February of this year, patient organizations presented a petition to our government to advocate for specialized care, and this resulted in 27 million euros being granted to support these clinics for the next 2 years, which leaves us also with the assignment for thorough evaluation, so that hopefully we'll be having evidence-based care which can be covered by the basic health insurance afterwards. In the summer, 3 academic medical centers were selected to spearhead these expertise centers, and a few months later we were seeing the first patients. So what do we do in these clinics? What I tell my patients is that we want to learn and generate knowledge while simultaneously offering the best possible care with the available evidence that we have. And how we do this is that we have created a structured care pathway in collaboration with experts in the field, as well as patient representatives, which we will apply and followed by a thorough evaluation. So already after the first 100 patients, we'll do a first round of evaluation looking at the diagnostics and therapeutics, and many more cycles of evaluation will follow. Excuse me. Importantly, we cannot see all patients who are in need of care, so we want to scale up and also involve secondary and possibly primary care providers. And so we are really also trying to see which are facilitating and limiting factors to do that. So a little bit of insight in this care pathway that we've got. We really take time with the patient in our clinics. We do a detailed history, which also includes some questionnaires. We do a complete physical examination, followed by additional testing, such as the nasaline test, which is demonstrated by myself and our nurse in one of our clinic rooms to screen for POTS or orthostatic intolerance. We do hand grip testing and a laboratory workup. After that, we categorize the patients into their most dominant symptom domain, and using a structured stepwise approach, we then give advice and offer certified or off-label therapies. So I'd like to give you a bit more insight into the patient journey and also the logistics behind this operation. Normally in the Netherlands, when your GP refers you, excuse me, you will be seen by a specialist. The waiting time may be a bit longer or shorter, but you will get seen. Thank you. However, within the first 2 weeks of opening referrals, we already received 10,000 referrals. So as you can imagine, there is no way that with 3 academic centers, we can cater for all their needs. So to channel all these referrals, we created a central point of access where GPs make a first referral, after which a random selection takes place, and only for selected patients, we receive a complete referral. We then process the referral to double check that patients meet inclusion criteria. So for instance, they need to have symptoms for at least a year, and common other causes of fatigue, such as anemia, must be ruled out. When we see them in our clinic, we take approximately 2.5 hours with them, and we realize that this is demanding for our patients, but they have also been involved in making the clinics in such a way that it is doable for them. So, for instance, they have the opportunity to lie down during the consultation. After that, we discuss every patient in our local MDT, and we also have a national multidisciplinary team every 3 to 4 weeks, where we can discuss difficult cases and also learn from each other and make sure that we align our management. After that, we propose our management plan to the patient, and we intend to follow them for a couple of months afterwards to evaluate our management plans. So as you can imagine, we are collecting a lot of data, and we hope to answer a lot of research questions as well. And we do this in collaboration with a national consortium of researchers, which is called Post-COVID Network Netherlands. Maybe some of you have heard of it. So I've listed just a few of the questions that we'll be looking at. So the first one is to look at different profiles, biological and clinical, and see if we can relate them to prognosis and the treatment possibilities that we are offering. We want to see what are the minimum required tests to be performed in patients with long COVID to rule out other causes, but also to guide maybe therapies. What is the effect of selected off-label treatments? And finally, and importantly, we want to look at facilitating and limiting factors to expand this care package to secondary and primary care, so that eventually, hopefully, all these patients who are now waiting can be seen. As you can imagine, this has been a huge team effort, and I've listed here some of my clinical colleagues, but many others were involved. And especially I'd like to mention the patient organizations who have been crucial in setting up these clinics. And with that, I'd like to thank you for your attention.